Welcome to our virtual connection. This session is part of a series of virtual connections that we have developed to educate families and caregivers of the services we provide here at Dell Children's. Dr. Kaufman is a board-certified, pediatric fellowship-trained spine and scoliosis surgeon who specializes in a wide range of spinal deformities, including idiopathic scoliosis and neuromuscular scoliosis. He is the chief of orthopedic surgery at Dell Children's Medical Center and an assistant professor of surgery and perioperative care at Dell Medical School.
So think of scoliosis as affecting about 3 to 4% of the population, most often females. Somewhere around 80-ish% of our Scoli patients are females. However, there's a disproportionate number of male patients who wind up going on to needing surgery. Not surprisingly, teenage boys aren't the best at following directions. So about 6 million people overall are affected in the United States, and it can be a fairly devastating diagnosis for the patients and families. A lot of these kids are totally fine, but there's a lot of stigma about scoliosis, and I think part of that comes from our end on the surgical side. We keep on saying deformity, deformity, deformity in front of these kids and families, and that's the word that we use, but that's got to be hard for somebody to hear, especially if you're a teenage girl hearing somebody saying you're deformed all the time. And in particular, the large curves with a lot of growth remaining have a very poor prognosis. We think of scoliosis as this problem of asymmetric growth. So while you're growing, if you're crooked, you have the potential to grow more crooked. Primarily, we're talking about adolescents being affected. The curves that are over 50 degrees tend to progress in adulthood and can go on to causing pain, deformity, and cardiopulmonary dysfunction. So really think about scoliosis as a three-dimensional deformity. That S shape that everybody sees from the front, that's an easy part to understand. What Dr. Geck and I are probably more judge ourselves on in terms of surgery is the spine from the side or the sagittal profile. Scoliosis is characterized by a loss of the normal thoracic kyphosis, or we say hypokyphosis. Their thoracic spines are often, frankly, lordotic, which can really be a big contributor to the cosmetic deformity. And then that rib hump that everybody picks up on exam is from the rotation of the bones in the spine. So they're moving the axial plane as well. And our goal in surgery is to correct all three of those planes simultaneously to give both the best radiographic and cosmetic correction of the deformity. We don't really know why idiopathic scoliosis occurs. There's one of our godfathers of pediatric orthopedics, this guy, Kay Wilkins, who's down in San Antonio. And Kay's a pretty funny guy. So I gave a talk like this in Guatemala, and he stood up and said, idiopathic just means that the pathology is real and the doctors are idiots. So I always kind of keep that in mind. There's been a lot of genetic links suggested for scoliosis, but nothing's really borne out consistently as a true genetic marker. The thought is that there's some mismatch between anterior overgrowth and posterior tethering of the spine, which creates this crankshaft-like effect. So while the spine is growing, it causes it to rotate as well. And the Hoder-Volkmann principle states that bone grows in response to distraction. So the thought is that the outside of the curve, the convexity, is going to grow more than the concavity, which is under a compressive force. We treat scoliosis in broad categories. If the curve is under 25 degrees, we just observe it with x-rays every once in a while. The kids who are still growing that have a curve between 25 and 40 degrees will be treated in a brace. That is about how happy every girl in a brace looks. So that's why we chose that picture for this. The braces work incredibly well. They're very effective. Happy to answer any other questions on bracing later, but it's a challenge for any family to wear those. And we use 50 degrees as our surgical cutoff. And some of the reasons why we use that number, there has been some natural history studies that have been done. The ones from Sweden were done in the early 1900s, and the ones from Iowa were done in like the 40s and 50s. And what they looked at were untreated scoliosis patients who had curves that were over 45 to 50 degrees, then followed them out for 35, 40 years. As you can imagine, doing long-term longitudinal natural history studies is incredibly difficult, so those numbers are very small. But what we have seen and what we sort of presume is that curves over 50 continue to progress despite skeletal maturity. And that can lead to a number of problems in addition to just the obvious deformity. So we think that pulmonary function really starts to get affected on a measurable standpoint when the curve is over 80 degrees. And there are high rates of back pain in adulthood if the curve is that large. If you look at quality of life outcome measures, so there's a lot of lower self-image scores, not surprising with a big deformity. There's a questionable effect on mental health as well, which I think just ties into that overall feeling of being deformed. The scoliosis itself is not the cause of death, but there are a number of case reports you can find out there. People dying from things like cor pulmonale, from having a curve that measures over 120, 130, 140 degrees, which can certainly happen in untreated cases. This is just a series of x-rays of a girl that we just fixed over in January, who's doing fantastic now. And you just get a sense of that natural history. She was 7 or 8 in that first picture on the left, and she's almost 17 in the picture on the right. So I think the key to remember for idiopathic surgery is that this is an elective surgery. We're doing them on a relative time sensitivity, but this is not something that needs to be done next week, or next month, or urgently. It's something that we're doing when the curve is large enough, meaning it's over 50 degrees. When the curve is progressing despite maturity, you don't have to operate on every 50-degree curve. There are 52-degree curves that are stable that people are fine with, and you can follow those. But that 52-degree curve at 14 that turns into a 62-degree curve at 17, you might want to start operating on that before it turns into an 82-degree curve when they're 30. And then it's Dr. Geck's problem and not mine anymore. And when a scoliosis surgeon recommends it, and I put that on there because, we're all pretty conservative from an operative standpoint. Surgery is really our last resort. So we're not just going to rush somebody to surgery for the sake of doing it. I've got plenty of girls who hate their 40-degree curve, but by the time they're 30, they won't care about it and they're going to be just fine. So we really want to know that from our end, it's the right decision to make. But most importantly, it's when it's right for the family. And that means that we really want to have a shared decision-making model where, in particular, I really like to involve the teenagers themselves in that decision. I mean, it's their back. They got to live with it. So in talking about our neuromuscular scoliosis program, so I love this table from one of our ortho textbooks. In that square right there, that is the idiopathic causes of scoliosis. And then everything else is what we would consider a neuromuscular type cause. There's obviously a lot of causes there. The challenges for our neuromuscular kids, they have a much higher infection risk. So we think our infection risk is 1 to 3% for idiopathic scoliosis. It's probably upwards of 10% for neuromuscular scoliosis. We are below those national kind of standards for both our idiopathic and our neuromuscular programs here, but that's the numbers that we quote people. Anybody who's on lower weight-bearing status, on chronic steroids, just generally sick in general, lower bone quality can be an issue. These kids can have very large curves that can be very stiff. They have a lot of medical comorbidities. They're often on a lot of medications. And then really you want to fully assess the family's goals of care. I just saw a lovely quadriplegic cerebral palsy kid yesterday who I followed for the last 3 years. He has an 85-degree curve. They do not want to have surgery. We've talked a lot about it. They are cool with kind of seeing how this natural history goes, and they're understanding that that may be part of his ultimate dying process, but the decision to have surgery is not the right decision for them. How we flatten the curve, and I mean how we flatten our curve of risk, but I thought, some timely headings in there. So ask for help, with our neuromuscular kids. I'm just an orthopedic surgeon. I'm a simple carpenter, really, and there's lots of medical comorbidities and things that I learned in med school and don't really remember anymore. So we ask for help. We do a preoperative care conference routinely for all of our medically complex patients. Once a month, I meet with the wonderful folks at the comprehensive care clinic, and we discuss anybody that they see who is scheduled for surgery coming up. And for any medically complex kid who's having surgery, we involve all of their care providers, both out of the hospital and in the hospital, for a conference, usually 2 or 3 weeks before their surgery. Our patient this past Monday had Duchenne dystrophy. So 3 weeks ago, we had a nice conference with his pulmonologist, his cardiologist, the ICU docs, the pediatric docs here in the hospital, our anesthesiologist. We had a plan of care. He has done great, even though he's a very complex child. We also have a formal neuromuscular spine pathway that we're working on optimizing to roll out to the community. We're using it very extensively in the comprehensive care clinic right now. A lot of that pathway is designed at optimizing nutrition and cardiopulmonary health. We're very obsessed about wound management, in particular in our neuromuscular kids. And for a lot of our neuromuscular kids, we use a dual surgeon approach. That's been shown to decrease operative time and decrease complication rates. So our goals of surgery in neuromuscular scoliosis: improve quality of life. This is a quality of life operation. Those x-rays are a young man who had a traumatic brain injury after being struck by a car. So he wasn't able to sit upright very well. And if you kind of read through that list, correcting the scoliosis is the last thing on my list in a neuromuscular patient. I want to balance their pelvis. More importantly, I want to improve their ability to sit upright. That's how they interact with their world, and prevent that curve from progressing. And if we get the curve a little straighter, that's just an added bonus in the end. And really, balanced pelvis is a happy life. Just showing you the last few, and by last few I mean like the last couple of weeks of our neuromuscular patients who we've been working on. So really getting that pelvis level. All of these children are going to do great going forward. They're going to be able to sit up really well. The girl on the left is lovely. I wish any had a chance to speak to her mom or have a question about a CP kid who needs spine surgery, she's a wonderful mom who's a really interesting lady, and she'll tell you how much better her daughter's life is now. I'm just one cog in the machine, just like Dr. Geck is. I don't do any of this alone. I'm very fortunate to have a wonderful team of people who help us out. I can't say enough good things about Bryce. In a comprehensive care clinic, I'll be forever in debt to Dr. Rahani and her team. They are absolutely wonderful and provide an amazing service to our community. Amanda Perot is an absolute delight to work with in the PICU. She makes my job so much easier. Scott Brandt probably wants to strangle me about 3 days a week, but I couldn't do my job without him. Jessica is my full work wife. She controls my work life, but she does a great job of it. She is a wonderful resource for all of you if you need anything. Our 3 North nursing staff, I will put them second to none across the country. Those men and women are absolutely fantastic. Their skill level is amazing to me. And really, thanks to all of you guys. I mean, these are difficult kids, and I couldn't do it without any of you. And really, all the credit goes to our wonderful families. They're truly fantastic. Some resources, we'll send these presentations out to you guys. These are great resources. Kids Health in particular is really helpful for families. And the other two, the Setting Scoliosis Straight and SRS, have good provider resources, both for deformity surgeons as well as for primary care docs and for families as well.
So another question that came in for Dr. Kaufman, it says, I know you've individually consulted regarding bracing and hopeful prevention of surgery, but could you go over the probability rates of wearing braces versus surgery?
So that brace trial is a really fantastic study that's been really impactful for us in the orthopedic surgery world to sort of look at who does well with bracing. So the study was done in New England Journal of Medicine in 2014, and they did a randomized controlled trial of bracing versus no bracing for girls with scoliosis who are skeletally immature. And what they found, and the study was actually stopped early by the FDA, that bracing was so effective that at avoiding surgery that it was not justifiable to not put people in a brace. So the numbers, if you look at that study, if you took everyone who was in a brace, your risk of avoiding surgery was about 76%. If you compare that to the about 42, 44% compared to not bracing at all, and the interesting thing is if you take the subgroup of patients out of that braced group, the ones who wore the brace like they were supposed to, their success rate at avoiding surgery is upwards of 90%. So it's an incredibly effective tool if you wear the brace as you're prescribed. It's usually at a minimum of 16 hours per day. And that was done with what's sort of the most traditional bracing method, is a Boston brace. There are lots of different kinds of braces. They all probably work relatively the same, but the hard part is that bracing works really well. It's just really challenging to get any kid to wear one.
I had prepared some questions because something that I've encountered just working with families is sometimes whenever you're thinking about your child getting a big surgery, you're not even sure what to ask. And so I think a lot of parents probably have some curiosities around what the inpatient experience is like and how long they're in the hospital, and if there's any time spent in the ICU and what that looks like.
We used to routinely send every patient to the ICU for one night. There's been some good research across the country that you don't need to do that. So last summer, I believe we stopped sending our idiopathic patients to the ICU. We haven't sent an idiopathic kid to the ICU in a year. We've had zero problems, and really all the credit there goes to our wonderful nursing staff. They're the reason that we've been able to do that. We generally expect people to be in the hospital after surgery for somewhere between 2 to 3 days. Really get you guys moving really very quickly on the path to recovery. I always tell families that my favorite thing is when they tell me that this wasn't as big of a deal as I thought it was going to be. It's really amazing. I mean, I've had girls go back to dancing, like competitive dance, 6 weeks after surgery. Some of these kids are really able to bounce back very quickly.
Another question that came in, is surgery an option for both C and S curves?
We don't operate in a vacuum. We discuss all these patients. Every kid who has surgery at Dell is discussed at a conference, and we frequently make small changes to our plans because we're able to consult with 5 fellowship-trained pediatric spine surgeons. And it's been incredibly helpful, and we review all of our cases before surgery, after surgery. We all learn from each other constantly, and it helps us all be better.
If surgery is recommended and my child plays competitive sports, what does it look like to return to those activities such as competitive basketball?
I'll say we're all a little bit different. I'm gonna qualify that with everybody's sort of comfort level is different. as far as returning to things like non-contact sports, around 3 months is fairly safe. I let people go back at 3 months without a problem from non-contact sports. Remember the goal of surgery is to obtain a fusion if you're getting a spine fusion. So that fusion can take about 6 months to set up. So going back to contact sports is about 6 months. Gymnasts, cheerleaders, volleyball players, football players, a couple kids who ride rodeo, who have all had spine fusions who are back doing everything. You never know there's anything wrong with them. So you can go back to all competitive sports once you're recovered. If that's 3 months, 6 months, somewhere in that range.
Another question that came in, do children typically gain any height after a surgery like this?
Yeah, my record is 3 inches for one kid, but that was a very, very crooked kid. So they get a little bit taller. I mean, they all want to be taller. You do get taller, but I think it's a combination of, we might measure you not as tall, but you're going to look a lot straighter because you're not going to have that deformity that we keep on mentioning. So it's a combo of those two things.
And then another question that I thought parents might be interested in was, if you have a very young child that still has a lot of growth left, how would you choose between bracing or casting? We've talked about bracing a decent amount, but for casting, what does that process look like? Just kind of a brief overview.
So spine casting is an incredibly powerful tool. The youngest kid that we'll put in a cast is around a year to a year and a half. And all that has just to do with safety with undergoing general anesthesia. So our parameters for casting younger kids, I go much lower. I'll cast a kid who's 30 or 35 degrees if they've been progressive, because their risk of having further progression is very high, and our likelihood of quote unquote curing their scoliosis is really very good. The challenge is that's a procedure that's done under general anesthesia. It's what I was doing this morning before I came up here. So they're anesthetized with an endotracheal tube, and we have a special table that we put on. It's a fiberglass body jacket, so the cast goes under their armpits and then over their hips. There's cutouts for the belly and around the hips and under the armpits as well. Like everything else, we all do things a little bit differently. I do waterproof casts. You can jump in the pool with a cast on. Got fun videos of kids doing backflips and jumping in the pool with their cast on. So it's something we asked them to wear for a while. I asked people to commit to a minimum of 4 to 5 casts, which means that they're getting changed every 3 to 4 months in the OR. And there's actually pediatrician from England who was of Indian descent and had very large scoliosis herself. Her name was Dr. Mehta, and she did a lot of the work on scoliosis casting and shown that with the right patient, you can truly cure a scoliosis. It's a big time commitment. It's something that those families, we're going to know each other for 15 years at least. And the goal is to cast a kid until either you fix the curve and it's gone, or you have gotten the curve to a small enough level where you can put them in a brace. What that age is really kid dependent. I've got a couple of 6-year-olds in cast right now because they're wild and wacky and they like their casts and they're fine in them, and they would take a brace off. Chris Bourne asked a question about pressure injuries from casts, and that's a great question, Chris. We're really careful about padding, and it's pretty rare that we get a pressure injury. The casts are really very tightly molded to the kids, so they don't rub. I've had one pressure injury in a cast so far, and that was probably more of a me fault than anything else.
And we provide different educational booklets for casting kids. We provide different things like dressings called Mepilex, which is kind of a cushiony dressing that we can put in different pressure areas. We provide moleskin, which goes around the edges of the cast to help pad casting. And if needed, then the surgeons can go in and trim cast if there's causing any pressure injuries at all also. So there's different things that we try and prevent those things. And if skin irritation comes up, which is normal, your skin almost has to toughen up a little bit for some of these casts. But after the first or second cast, you'll notice that the skin irritation goes down also.
It dialed it. It takes me about the first 2, everybody's a little bit different. It's a little hard to figure out what's right and exactly how much pressure to put, where to put the molds, and we kind of follow general principles. But I feel like my 3rd cast on a kid is usually the best one, and they get better after that.
There's a question about physical therapy involvement. Is there any involvement preoperatively with some of our complex kids that have any DME? And then what does physical therapy look like after surgery also?
There's a scoliosis-specific therapy program called Schroth therapy that's gaining a lot of, I would say, internet traction now. I think Schroth definitely has a role for the brace kids. I think of it as an adjunct to brace treatment and not a substitute, and that's really a key point. If you talk to somebody who's really a reasonable Schroth provider, they'll tell you the same thing. It is a very intensive therapy program. It requires a lot of body control, and we offer it to patients all the time, but I tell people to go watch some videos on it and figure out if it's something you're really gonna be able to commit to. There is not data to show that therapy alone will prevent progression of your scoliosis. It may be as an adjunct to bracing, and maybe it's just because you focus more on wearing your brace if you're doing therapy as well. And then for postoperatively, we very rarely do therapy after idiopathic scoliosis. Honestly, the kids just don't need it.
Physical therapy will work with you while you're inpatient recovering, but after you leave the hospital, then it's really kind of if you're having muscle stiffness or surgeon preference after a conversation at your postoperative appointment, physical therapy will work with you. Another note on physical therapy for our neuromuscular kids, if you have specific devices, medical devices, like a formed wheelchair or anything like that, then we're really trying to look at physical therapy, seeing you preoperatively at one of your hospital pre-op visits to come assess your equipment and kind of see how we can help that discharge planning for you also. A question that came in was thoughts on anterior scoliosis correction for skeletally mature AIS patients.
Remember that those tethers are growth modulating devices and they're meant to be temporary. They're not meant to stay in forever. There's be very, very few patients who won't have a second surgery to either remove a tether, just to cut the tether so it's not still correcting, take it out, or convert to a different surgery. I would just be cautious of the person who is a hammer or every nail they put in front of them, they're going to use as a hammer, right? I mean, there's not a right choice for everything. And I think it's nice to think of a fusionless surgery as an adult. I'd be hesitant to do it.
We had a parent ask about understanding that this could vary from child to child. What can they be doing other than trying to get their child to wear a brace for 16 hours a day? Is there anything else they could be doing to try and prevent the curve progression?
I think so. We talked a little bit about Schroth therapy is one method. I caution people really against chiropractic manipulation. I think there's a few chiropractic websites out there that are very slick. And I think if you have to be very careful, and if you really read their data, there really is no evidence that chiropractic manipulation has any effect on scoliosis. One of the national committees I serve on is the non-op committee for the SRS, for the Scoliosis Research Society. So we talk about this stuff all the time about what's the best way to do it. Honestly, it's so hard, and we just need to build a better mousetrap, and that means we need a better brace or a better solution. I think therapy can be helpful. It's just really hard. Some of it's just luck, and you're fighting this race against time.
And then is scoliosis an inherited condition, and how early can it be diagnosed? Can it be diagnosed in the fetus or in the womb?
I think, the genetic data on scoliosis has been very variable. Every couple of years there's somebody that comes out with some new genetic marker that this is the thing. And then you start, as Dr. Geck just described, applying it to a wider population. And then you realize that, well, it doesn't really fit. So Scoli score was this, I think it was like 24 genetic markers. The theory was we're going to do a blood test of you, figure out, quote unquote, what kind of scoliosis you have based on your genes. Then we can figure out if you're going to progress or not. So if you have one of the genetic markers that you have a non-progressive scoliosis, then your 30-degree curve doesn't need to be braced, because those kids do exist. The problem was the test was absolutely horrible in terms of really predicting if it was going to work or not. So basically nobody uses it anymore. I think maybe someday somebody will figure it out, but it's also so hard. I just talked to a mom last week who is a mom of two identical twin boys, where one kid has a curve that's braced and the other kid has no curve. So at that point, I am now lost and I don't understand scoliosis at all.
Well, and the last big question, why choose Dell Children's to have surgery for my child? Why not choose somewhere else in Texas or anywhere else in the country rather than Dell Children's?
It's something I'm extremely passionate about. I'm extremely proud to say that, I work at Dell Children's, that we're part of the spine program, and I would happily hold our program, our results up against anyone else in the country, no matter what center you come up with. I think a large portion of that is that you'll find a consistent message across the board from every person you interact with. Our goal is that from the moment you check into the hospital to the moment you leave, every person you speak to knows the plan. that they have the sense of how we're going to manage your child, how we're going to work through your scoliosis surgery, and that we've all done it before. We don't want it to ever seem like it's not a big deal, but when you get to a point where everyone feels like things are routine, that's when you can really start working on making the abnormal events even less common. And I think that Dr. Geck and I are also two people who we're not complacent. So once we're not satisfied, we're not as good as we can be. We can always be better. And, good enough is never good enough. Better is better, right? So that's where our focus lies, and that's where our passion lies. It's something we both love to do. And we're just so proud that we can bring it to our community. And I think, we want our patients to go out there and tell people how well they're doing, how great we're doing. I mean, I think it's fantastic. I'm just gonna, how many surgeries do we do a year for this? To respond to that. So in general, we consider a high volume scoliosis surgeon someone who does around 25 scoliosis surgeries a year. Both Dr. Geck and I individually well exceed that. And we also have 3 other spine surgeons who are here. I think last year we did 70 idiopathic, never mind, 90 idiopathic kids. And that's, so we're about 100 a year, and that's going up every year. It is on a very, very rapid upward trend. I think you always feel like, where would you send your own kid? And, if one of my kids needed scoliosis surgery, I wouldn't hesitate. I mean, I wouldn't do it, that'd be weird, but I wouldn't hesitate to bring them here. I put them in Dr. Geck's hands, I put them in one of my partner's hands, and I wouldn't have a second hesitation about it. It's a wonderful hospital for anything. So yeah, we're really good at what we do. We're proud of it. We're happy to tell you that.
Another question came in from a parent that is there any studies for higher order multiples like triplets or more having a higher chance of scoliosis due to any growth restrictions during development?
No, I don't think so. I think part of it is that we're just not clear on what causes scoliosis specifically. So it's hard to know if this is we call like a packaging disorder, something like clubfoot, or is this something like a hip dysplasia that's not really necessarily related to positioning during pregnancy. I'm sorry, not hip dysplasia, like scoliosis, which is not really related to positioning during pregnancy.
How long do you see the kids post-surgery? How long do you follow them afterwards?
To be clear, I will always see my post-op patients forever. Part of the beauty of the way our practice structure that we can see anybody. Or generally, we're seeing patients a few weeks after surgery, a couple months after surgery, 6 months, at a year afterwards, and then yearly after that. That's the general guideline.
Thank you guys so much for tuning in.